Again, my name is Berey, and today I'll be talking about affective and individual difference predictors of cannabis smoking topography. So I wanted to state at the outset that all of us have no conflicts of interest to disclose, but that this presentation does not necessarily represent the official views or policy of the NIH, VA, or the United States government. But to dive right in, as of 2023, there were only 3 states in the US that did not have any public access, either recreational or medical cannabis program. And their qualifying conditions for medical cannabis are vast, that include but are not limited to things like autism spectrum disorder, PTSD, chronic pain, and epilepsy. However, our knowledge about how to actually use the cannabis for these medical conditions, so in particular things like dosing, timing, etc., remain limited. So it's equally important in terms of etiology and prevention that research has predominantly focused on cannabis use frequency and quantity. And so there's really, it's important to look at more nuanced behaviors like cannabis smoking topography to help inform both how to best use cannabis for medical purposes, but also to identify when and for whom might smoking be associated with negative outcomes. So before we get into how cannabis smoking topographies can inform all of these different things, it's important that we first discuss what do we mean by smoking topography. So I have a table of key terms up on the left-hand side of the screen and a hypothetical smoking behavior, if you will, on the right. So when we're talking about topography, what we're really talking about are the specific characteristics about how one smokes during a given session. And these types of behaviors include things like puff volume, or the actual size of the puff duration, or how long a particular puff lasts, puff velocity, which considers both the volume and the duration of the puff, and lastly, inter-puff interval, which is the time between the end of one puff and the start of the next puff. So broadly speaking, smoking topography is relevant for various different reasons, but to just highlight a few, prior research shows that certain cigarette smoking topographies are linked to greater exposure to carcinogenic compounds. And on the alcohol side of things, research shows that specific drinking topographies are associated with more negative alcohol consequences. So in addition, not only does smoking topography differ between individuals, but we're also talking about a dynamic process that differs within individuals based on key and different contextual factors. Yet, to our knowledge, our understanding of cannabis smoking topography relative to that of cigarette and alcohol is relatively understudied. And addressing this knowledge gap is crucial because it can tell us about smoking patterns that differ between individuals, as well as specific contexts that predict riskier smoking topography profiles within an individual. So the goals of today's study are to identify how different contextual factors relate to cannabis smoking topography, with an emphasis on negative affect and craving, and also on an exploratory basis to understand differences in smoking topography based on participants' baseline use of cannabis for medical or recreational purposes. So diving right into the methods, these data come from a NIDA-funded study on the behavioral economic analysis of marijuana demand. The participant age range in this study was 18 to 50. As you can see on the right-hand side of the screen, the sample was primarily white, male, and in their early 20s. Participants were excluded from the study if they had a medical cannabis card for reasons unrelated to this talk here. But all participants were required to report on average weekly cannabis use in the last month and test positive for THC to biologically verify recent cannabis use at all in-person appointments. So once participants attended this in-person baseline appointment, everyone completed self-reports on various socio-demographic factors and cannabis use. And I specifically want to point out that participants answered 2 single items assessing the frequency of cannabis use for therapeutic purposes, as well as the proportion of cannabis that participants classified as being recreational versus medicinal or therapeutic in nature. And I just want to make clear that for the remainder of the talk, I'm going to be referring to therapeutic or medicinal cannabis use from these two single items as medical cannabis use. Participants also went through various semi-structured interviews, and eligible participants were then scheduled for a cannabis self-administration session. So on the day of the session itself, and before participants arrived to the lab, study staff prepared 2 non-filtered cannabis cigarettes obtained from the night of drug supply, and study staff also cleaned and calibrated the CREST device. Immediately prior to the start of the smoking portion of the session, participants completed the PANIS to assess positive and negative affect, as well as the marijuana craving questionnaire to assess phase of craving. Afterwards, participants were moved into a ventilated room where they had 1 hour to smoke up to 2 cannabis cigarettes ad libitum that were attached to that CREST device. And to address our main aims and hypotheses, we tested a series of hierarchical multiple regressions to examine whether these contextual factors and the proportion of medical to recreational cannabis use predicted different smoking topographies. And then we also tested an ANOVA with planned contrast to examine whether smoking topography differed based on one's frequency of baseline medical cannabis use. So looking at the sample as a whole, over half of the participants used or reported using cannabis for medical purposes at least monthly at baseline. And this translates to approximately 25% of the time that they recorded using cannabis. In terms of the session itself, participants reported relatively low levels of negative affect and craving immediately prior to the smoking portion of the session. And in addition, negative affect was not significantly correlated with any smoking topography outcome, and craving was only significantly associated with interpuff intervals. And in terms of the ad-lib session itself, on average, participants spent approximately 21 minutes from the start of the first puff to the end of the last puff that they took. And on average, the sample took approximately 26 puffs per session. And over 80% of the sample chose to smoke at least 1 puff from both cigarettes. So moving on to the regression models, before we dive into the actual results themselves, just want to let everyone know that these are presented in terms or based on individual topography outcomes. So when we controlled for craving, baseline cannabis use, and sociodemographic factors, we found that a higher proportion of medical cannabis use predicted a higher puff count, greater total puff volume, and greater average puff velocity. Likewise, we also found that older age predicted shorter average puff durations, whereas male sex was associated with longer average puff durations. But in these models, the proportion of medical cannabis use was not associated with average puff durations. And lastly, we found that older age predicted longer interpuff intervals, whereas using more cannabis at baseline was associated with shorter interpuff intervals. And like the last slide, the proportion of medical to recreational cannabis use was not associated with interpuff intervals. So moving on to the ANOVA results here. So before I dive in here, the figure bars include group mean values based on each of the response options from that single item, but the bars themselves are color-coded to align with this specific planned contrast. So we found a significant large effect difference in total puff count for participants who use medical cannabis at least monthly compared to less than monthly. And while not included in these slides for the sake of time, we found no significant differences when comparing participants who use medical cannabis monthly or less versus weekly or more, or weekly or less versus daily or almost daily. We similarly found a significant large effect difference in total smoke volume for participants who use medical cannabis at least monthly compared to less than monthly. However, there were no significant differences in those other two contrasts, so monthly or less versus weekly or more, or weekly or less versus daily or almost daily. And lastly, we found a significant large effect difference in average puff velocity for participants who use medical cannabis at least monthly compared to less than monthly, as well as participants who used medical cannabis at least weekly compared to monthly or less. However, there were no significant differences between the groups that use weekly or less versus daily or almost daily. So some of the main takeaways that I want everyone to have from this study are that with, one exception, these contextual factors, specifically negative affect and craving, were not associated with cannabis smoking topographies. However, we did find that frequency of medical cannabis use, our sociodemographic factors like age and sex, and more baseline cannabis use were associated with smoking topographies in the lab. So these findings also have some potentially relevant clinical and public health implications. So for one, these results can potentially help to inform clinicians about way to talk to patients who are either interested in using medical cannabis or who are already using it. And so specifically that how someone uses cannabis just beyond frequency and quantity can have potentially unintended consequences like excessive smoke exposure. And so, for example, tying in the concept of protective behavioral strategies, similar to what we know about this research in the alcohol realm, and this can mean something like discussions about in-puff intervals and tying in things like pacing and spacing as a way to mitigate some of the potential harms. And relatedly, public health campaigns have done a really nice job of informing the public about some of the legal and health-related impacts of cannabis. So, for example, things like the Marijuana Cannabis Control Commission and the Colorado Department of Public Health and Education and Environment. But perhaps in the future, some of these campaigns could also be tailored to discuss how different smoking topographies can be more or less harmful. And lastly, some of the study highlights also speak to important future directions. So the present study focused on smoking topography using from flower cannabis obtained from the night drug supply. But it's really imperative in the future that research assesses topography across various different modes, formulations, and different cannabinoid concentrations. Similarly, this line of research can really be advanced by leveraging the full spectrum of technologies to examine how topography relates to other relevant health outcomes over time and in the real world. And lastly, the sample consisted of primarily white, male, young adults who all reported relatively low levels of craving and negative affect right before smoking. So it's really necessary that future studies are intentional about recruiting individuals who are more representative of our society at large, while also being intentional about crafting methods that aim to produce more variability in affective and contextual states.